At dawn on the morning of the 6th of June, 1944, 225 Rangers jumped off the British landing craft and ran to the bottom of these cliffs. Their mission was one of the most difficult and daring of the invasion: to climb these sheer and desolate cliffs and take out the enemy guns. The Rangers looked up and saw the enemy soldiers at the edge of the cliffs shooting down at them with machine guns and throwing grenades. And the American Rangers began to climb. When one Ranger fell, another would take his place. When one rope was cut, a Ranger would grab another and begin his climb again. They climbed, shot back, and held their footing. Soon, one by one, the Rangers pulled themselves over the top, and in seizing the firm land at the top of these cliffs, they began to seize back the continent of Europe.
The teamwork and determination displayed on that fateful day at Pointe du Hoc not only demonstrates the best of the United States Army, but it also represents our mission at the Association of the United States Army. Soldiers supporting soldiers. For almost 75 years, AUSA has served soldiers, providing a voice for the Army, and celebrated those who have helped the Army community. We've experienced tremendous growth and are now over 1 million members strong and growing. We continue to provide essential services to soldiers, civilians, retirees, veterans, and family members. We engage with the Army, Congress, industry partners, and communities across the globe. And we work to advance national security and promote greater recognition of the Army's vital role in American life. But we're not stopping there. We're evolving the way we educate, inform, and connect America to the Army. We're developing our Center for Leadership to inspire Army leaders. We're investing in our Army communities with a broader membership reach. And we're building stronger links between generations to support the Army's critical needs. As we charted AUSA's path for the future, we realized we needed a new symbol to represent what we do. A logo inspired by the significance of the soldier experience and the Army story. A logo inspired by our focus on people. Because, as General Creighton Abrams said, people aren't in the Army. They are the Army. A logo inspired by the achievements of those brave soldiers at Pointe du Hoc on that fateful day in 1944. This is that emblem. AUSA. It takes a team. Soldiers, families, civilians, retirees, veterans, industry, and you.
The Association of the United States Army is pleased to welcome you to AUSA's Noon Report webinar series. This webinar series features presentation by senior Army leaders responsible for key programs and initiatives. It also features contemporary military authors who weave together the past, present, and future story of the United States Army. Kicking off today's webinar is AUSA's Vice President of Leadership and Education, Lieutenant General Retired Les Smith.
Good afternoon, and welcome to the Association of the United States Army's Noon Report. Thank you for joining us for today's webinar. We appreciate your support as partners in defense of our nation. Joining us today is Dr. Lester Martinez Lopez, Assistant Secretary of Defense for Health Affairs. Please take advantage of having Dr. Martinez Lopez here to ask questions. You can use the Question and Answer tab on the right side of your screen to submit a question. After the discussion, we will take as many questions as possible. You can find the full bio for Dr. Martinez Lopez and our moderator, Major General Joseph Caravalho, in the Handouts tab. As stated, the moderator for today's discussion is Major General Retired Joseph Caravalho, MD. Dr. Caravalho leads the Henry M. Jackson Foundation for the Advancement of Military Medicine, a private, not-for-profit organization established in 1983 and authorized by the U.S. Congress, whose mission is to partner to advance medicine for the mutual benefit of military and civilian health. As president and CEO, Dr. Caravalho guides the strategic vision for HJF and its global workforce in pursuit of its vital mission. He served in the Army for 38 years. His last assignment was as the Army Deputy Surgeon General and then as a Joint Staff Surgeon, serving as the Chief Medical Advisor to the Chairman of the Joint Chiefs of Staff. He graduated with a medical doctorate from the Uniformed Services University of Health Sciences in 1983. He also has a BA in math from Gonzaga University and an MA in Strategic Studies from the Army War College. He's board certified in internal medicine, nuclear medicine, and cardiology. And in 2019, he received an honorary Doctor of Law degree from Gonzaga University. Dr. Caravalho, I turn the floor over to you.
Thank you, General Smith. Dr. Lester Martinez Lopez is currently serving as the Assistant Secretary of Defense for Health Affairs, a family medicine physician who retired from the Army as a Major General and was the first Latino to head the Army Medical Research and Materiel Command, where he directed the Army's worldwide medical research, acquisition, and logistics program. His experience in military medicine also includes tours as the Commanding General of the Center for Health Promotion and Preventive Medicine, where he directed a worldwide public health organization and had command of 3 military hospitals. After retiring from the Army, he served as the Chief Medical Officer at the Brandon Regional Hospital in Florida and Senior Vice President and Administrator of the Lyndon B. Johnson General Hospital in Texas. As a student, he graduated from the University of Puerto Rico School of Medicine with a Doctor of Medicine degree, and he has a Master of Public Health degree from Johns Hopkins University. Dr. Martinez Lopez, welcome.
Oh, thank you.
You are the senior most medical advisor to the Secretary of Defense, a cabinet position. And with that, you have responsibility for the military healthcare delivery system, for deployment healthcare, research and development within the military structure. So I'd like to ask you a few questions about each of those topics. With regards to the MHS healthcare delivery benefit, a recent NPR article indicates that federal designations of inadequate healthcare areas, so-called healthcare deserts, impact accessible care in the fields of OBGYN, mental health, and primary family care. NPR indicates 50% of military installations are in at least one of these deserts. Do you agree with this data?
Yeah, I mean, operationally, the military, Army, Navy, and Air Force has to have dispersed geography in the country and abroad as well. In many of these places, the network and the care is not that available. We have to make sure that our people are taken care of. That's the number one issue for the Secretary, taking care of people, and we take that very seriously. So the challenge for us is that's a reality. So now what are we going to do about it? We try to understand the network that is available to us. And when there is a gap there, then we need to supplement that gap either with military medical personnel. In some places, we can hire civilians, so we do that. And if that's not the case, then we need to leverage technology, telemedicine, circuit riders, doctors who may go to different bases to provide the care on a regular basis if that's needed. And that's how we approach it. I think quite often people say, civilians have the choice of living there or not. In the military, we don't give you a choice. We order people to places, and then it rests upon us to provide the care. But yeah, it's a reality of American medicine. If you are in places like Fort Irwin, California, that's going to be very isolated. If you're in a place like, Sama, Korea, that's going to be isolated. So we have to provide the care, and we do.
Okay, thank you. Have you seen any impact on retention because of this?
Well, no, I personally have not.
Mhm.
But, we work and strive to make the environment safe, that the care is delivered. Because one of the main reasons of retention, it would be that you not only take care of the service member, but you take care of the family members, right?
Mhm.
So we have to make sure that that enters into the formula. So if we cannot assure that we're going to do that, then we're in a losing proposition. We don't want to be there.
Mhm.
We want to be in a winning proposition, and we work really hard to make that happen.
Okay, thank you. I'm going to move into deployment healthcare. And this covers the DHA, or Defense Health Agency Combat Support Agency mission. So with the healthcare delivery benefit challenges, how does the DHA maintain its CSA, or Combat Support Agency mission, to support the combatant commanders and their respective deployed joint force?
That's a very good question, General Caravalho. I mean, the issue is this. The DHA is a new enterprise. It's the largest reorganization in the Department of Defense since we created the Air Force, the U.S. Air Force. I mean, over 100,000 people working in DHA across the globe. So that we are in that growing stage. And the growing stage is, how do we now assume in the system, how DHA assumes some responsibility innate to the DHA, and how the services also assume responsibility. It's a system, right?
Mhm.
So the military healthcare system consists of DHA, Army, Navy, Air Force, Medical Department, and USAs. So those are the five big elements of the system. So we are in that environment where we're learning how to do things. For example, DHA will be responsible for training the force. Many of the physicians and nurses and techs, where do they get trained? They get trained in the military treatment facilities that now belong to DHA.
Mhm.
That's one responsibility. Number two, all the casualties are coming. They're coming back to the States. Where are they going to come back? They're coming back to military treatment facilities that right now belong to DHA, right? So we need to make sure that this is a seamless process, that we look at it as a system. There's not which part of the system is more important. No, all the elements of the systems are important. So in the go-to-war mission example, so role 1, the medic, is critically important. Role 2, the battalion is critically important. The combat support is critically important. But the Walter Reeds and the BAMCs, the Brooke Army Medical Center, that's important. So you cannot take one at the expense of the other. You have to think of the continuum of care and how so DHA will play a critical role in that. And then in research, so if we have gaps, so there is an element of research that also the agency will be responsible for. There are elements of public health, making sure that people are not exposed to things that we don't need to expose them to, right? So we are working through all this. There's actually a capability study that is undergoing now to ascertain the process, and there is a lot of negotiations between the services and DHA to make sure that expectation that we're going to deliver the right care to every service member that is wounded or injured is there, and there is no seams in that continuum of care, right?
Mm-hmm.
And so more to come. Is a journey, but we're moving along.
Mm-hmm.
I'm moving, and I feel very comfortable that we're doing the right thing to ascertain that care is there if needed.
You know, I've always thought that the medical was challenged in that it has a real world, I'll say, garrison mission alongside a real world deployed mission. The infantry doesn't have that. Field artillery doesn't have the fighter pilots don't have that. And this real world garrison mission is the healthcare delivery benefit or an entitlement for those beneficiaries of the military, uniformed and their family members, retirees, etc. So that makes me think that there's a challenge that DHA has to provide this benefit to those eligible and this very important CSA mission. And do you find that it is tough to keep both going? Or is it one then the other? Or how do you balance that?
It's very interesting because that question, it carries on. And the question, who's on first? Healthcare delivery or readiness? And the answer is both. We've been in this dilemma for 70 or 80 years. So I'm not talking about anything new. When you commanded and I commanded hospitals, we always have that friction, right? The healthcare delivery of today and making sure that the medical force was ready to deploy. So we have to come out to, we cannot do readiness without patients. It's illogical, right? The only way we can ascertain readiness is by providing that everyday care in our MTFs. On the other side, it's an issue of priority, right? So if we go to war and there's a service member coming wounded, everybody understands he takes priority. And then we try to strive to make space available for the rest of the beneficiaries. This is what we experienced in the Second World War. This is what we experienced in Vietnam. This is what we experienced in Korea. This is what we experienced just in the last war. And the next conflict, it will be exactly the same way. So I think it's a magical thinking that we can delink readiness from everyday care. So we need to, it's critical to our readiness, it's critical to our system, and we need to think about it as a continuum. I mean, again, it's a system thinking that we need to make sure that, okay, and the other part of the system is, you know, you may be a soldier, but you may be taken care of by the Navy, in a Navy hospital. Or you may be a sailor and you may find yourself in an Army hospital. Or you may be an airman taking care of, a sailor or a soldier. Because you never know. So all the parts of the system have to be ready to do their part to make sure your care is there. So it's who's on first, who's more important? No, all of them. We have to really put that thinking process in place.
I still believe what you do is more complex, arguably, by the other branches than any other branch, because what you're training for is not simply train like you fight. Everyone else can do that, train like you fight, but your garrison mission can be completely different than what is expected downrange. As an example, a general surgeon is going to get a lot of training in minimally invasive surgery, never needed downrange. So you have to meet those requirements to get them through their residency, and then you have to have them exposed to the readiness requirements. The bottom line is I agree with you, and it's very complex to fit this puzzle together, and I applaud you for attacking that. If I can transition now to large-scale combat operations. So there are lessons learned being captured from the conflict in Ukraine, which poses much different circumstances than what the U.S. has experienced in its military operations in Iraq, Afghanistan, or against terrorist networks across the globe. So coupled with the idea that we mustn't prepare for our last war, how are you helping ensure the department is as prepared as possible for LSCO?
It's a wicked problem. I mean, because what we're envisioning in the future is an environment where the medevac in 30 minutes may not be possible. We may have to wait. If we don't have air superiority, that'll be a challenge. There will be more demand. The level and complexity of the injuries may be far greater, as we've seen from the Ukraine. That poses a risk for infections and other things, so it makes it a far more complex case to deal with. We may require a lot more blood than we ever dream of, and so there's a lot of issues here. The security, the delivery of drugs is going to be a very distributed battlefield. So the logistics of making available blood, drugs, equipment, personnel will be a challenge. So we need to address each and every one of them. And on top of that, the icing on the cake is, the mental health issues that we understand from as we have grown into this environment is a major challenge. We may not have enough people. So how do we train? what technology we can leverage to close that gap so we can take good care of the people we entrusted to. And by the way, this is about trust, right? So we are entrusted the service, the care of these service members, and they expect the best. So we're closing the gap in many ways. We're closing the gap by a discussion, as I said, what will be the role of DHA and the roles of the services, but also what technology we need to bring. So we're doing investment in science and technology and research to close the gaps. We're talking to our partners from Europe and around the world and see how we work issues like blood. We have it in common. Issues like drugs, we have it in common. So how can we partner? We're leveraging the bigger government, so the VA. So we're leveraging everything we can leverage to trying to come out with the answers. But still, I wish I could tell you I have the answers for every single problem we face, and we don't. But we need to really work it. We're working it hard. The goal is not to disappoint. The goal is to really keep that trust going. And I tell you what, as I go around, the people we have, they're great. They're great people. They're committed. And that gives me the light that, yep, we'll be able to not only succeed, but excel in this enterprise.
Well, I thank you. I am very proud of what the department is doing with regards to trying to learn from the Ukrainian surgeons and what have you. But you're constrained by the fact that the president wants no boots on the ground in Ukraine. How are you getting after some lessons learned without being in Ukraine?
Well, we have, on two accounts, we are training, and we have been training Ukrainian medics and surgeons, helping with their training outside of Ukraine, but still keeping them up to speed on what would be the best way for them to take care of their casualties. But we have other entities that are going into the Ukraine that are feeding us information, lessons learned, and we're cataloging all those lessons learned to make sure we don't miss them as we prepare for the next one ourselves, right? So it's an ongoing process, and I feel very comfortable. We have a lot of interfaces. Like this month, we're going to have a big research meeting down in Orlando for the whole MHS, and there will be a large Ukrainian delegation that is coming, so they can learn from us and we can learn from them. So, and it's not just the Ukrainian. We have all our partners around the world. They're feeding us information from their different conflicts, and so we're learning. And not only do we learn, we also give them lessons learned. So it's a two-way street.
Sure.
Cannot be a one-way street. And but this is not new. We've been doing this for a good long time.
Not to disrupt your train of thought, but I'm going to come back to your MHS healthcare delivery benefit. How is the nationwide shortage of medical professionals impacting the MHS?
Oh, man. You know, we were having a challenge, for example, in mental health. We were having a challenge before COVID. After COVID, many professionals say enough. They have all the fun they were going to have, and they decided to retire. So that puts more stress on the system. In some places, worse than others. That means we are competing for the same manpower pool, the same trust, right? So we have to be better at this competition game, and we have to be more appealing. I think if you come to us, I always say the driver you have to be willing to serve. The reason you come to us is because you see a greater good than just yourself. You have a calling to really help those that serve, right? That has to be number one. But then we have to create an environment that we're competitive, whether it's in uniform or whether it's as a civilian. We have to create a very competitive environment, whether it's on salary, incentives, and other things, and we're just doing that. So, but still, it's a tough competition. And I don't see this getting any easier in the near future.
Okay. When you were talking about Ukraine, the examples you gave were, one could group into management of the combat wounded. But you and I both know as physicians, non-surgeon physicians, up to 80% of the casualties, those who are no longer employable as an infantryman, let's say, or infantrywoman, it would be from disease and non-battle injury. One thing that I had read was there is de facto trench warfare scenarios in Ukraine where when there are thousands of drones every day, it is no longer concealment is important, is an imperative. So in a trench, just kind of stuck in a trench. And then things that are associated with that, rodents, disease, and what have you, is some of the things that I read. So with that, let me talk about multi-drug resistant organisms. So there are reports of this encounter in Ukraine, different from what we experienced in Iraq and Afghanistan, which was the major culprit was Acinetobacter back then. So now this is Klebsiella, more virulent and resistant. So what steps are you taking to address multi-drug resistant organisms from returning to Oconus, launch stool, and Conus, MTFs?
I tell you, this is in a way bad news, but it's a good news story. We have been monitoring this multi-drug resistant organism very closely, long way, 2009. We actually created an institute within the Walter Reed Institute Research to monitor this worldwide. So that informed us and the clinical component of how to respond to them. Yes, the Ukraine posed a challenge, but it's not a new challenge. It's been around for a while. So we have a global surveillance that is looking at not only what's happening in the Ukraine, but what's happening around the world. So we're not surprised, right? That will inform how we're going to treat these patients. And also will inform if we need to repatriate those patients, how to protect the other patients in the hospitals from getting those kind of infections. So I think never claim glory that you are on top of the game, but I feel very comfortable that we have a very robust system that has been tracking this out for many, many years. By the way, we're not only doing it for us, we're doing it for the country. Mm-hmm. So many of this surveillance we're providing the CDC and the other whole government, so to inform them, because typically we may be the tip of the spear in Africa or South America, someplace else, and we see this coming, and we can prepare the country how to best respond. So I feel very comfortable that we have a good, robust system to put the surveillance, try to figure out early on what's happening, put the countermeasures in place, right treatment for the patients, and prevention processes as they come back home.
Great, thank you. I do applaud the department for its global surveillance program, really looking at what may be present anywhere the president may send us.
And this is something we always have been done, not only for DOD, we have done this for the country. Mm-hmm. So people don't understand, sometimes they don't even know, but this is a part that we have to be extremely, extremely proud, that the military health system is not just looking internal to what's best for the department, but also is looking after the well-being of the Americans at large.
I think even though you are a requirements-driven organization when you do research and you're focused on primarily that cohort, let's say 18 to 45 or 50, the American warfighter, and by extension their families, even though you're constrained by that, what you're doing is applicable and ultimately to the benefit of global health. And that's what excited me when I was in the military. I'm really proud of you all for doing that now. I'm going to transition now to brain injury. A recent New York Times article suggested NAVSPEC warfare leadership was not aware of the DoD's brain repository's findings of barotrauma-related brain interface injury, which is different from the chronic traumatic encephalopathy seen among NFL players. So can you comment on what DoD is doing in this arena, and then how it is keeping leadership informed of findings and medical countermeasures, if any?
Yeah, I'm old enough to remember when, long time ago, before 2000, if we say about TBI, what I thought about was a brain injury, maybe with blood or maybe, fracture of the skull or something like that. That's what the definition was. And we've been in this road of discovery, and now we understand that there are other mechanisms to impact the brain. We've been doing blast overpressure research, my God, for forever. But I remember too, my gray hairs, before 2000, the main focus was hearing, lung, but we were not looking at brain as part of this blast overpressure as an organ that was being affected by blast overpressure. Well, this is a road of discovery, right? So now we know better. Now we know that, yes, all this blast overpressure has an effect, not only on the lungs and the hearing, but a critical organ like the brain. So we've been doing research for actually leading the country on the research on this area, because it's not just us. Many Americans are affected by the same deal. So we've been doing research and we're closing the gap. I'm very proud to tell you, the department is being proactive, trying to minimize the risk. I mean, now, there's always going to be risk in our business, but in our business, I don't want to expose anyone to unnecessary risk. So I think our first target on blast overpressure is training. Can we minimize the exposure of blast overtraining in training? So the services are really looking hard at this. How can we do that if we don't need to be exposed to blast overpressure? Why should we? So is there a way that I can achieve the training goals, either by don't exposing you or minimizing the exposure, right? And the answer is probably yes. I went for Liberty and talked to some special forces, and they're doing like the breaching of doors. They're now, instead of putting the whole charge, they're minimizing the charge, still achieving the same goals, but minimizing, dropping down the exposure to the service members. So that's the way we need to tackle it out. Now, it's a road of discovery. We're not done yet. Everybody, it would be great if we have all the answers, but we're working really in a diligent way to understand better. It's not just how much, but how frequent. So those are two variables that we need to work through it. And at the end of the day, I don't need to wait for science to tell me if there's a way I can cut the exposure. Let's do it. And that we're working with the leadership of the departments. It's not just the Army, it's Navy and Air Force. Mm-hmm. They're having the same issues. Mm-hmm. We need to work really hard to, at least in the training environment, minimize it in the operational environment as well. Mm-hmm. There is a little bit more of a trade-off, right? If they're coming at you and you think you may die if you don't fire that weapon, then you're probably going to fire the weapon. But there is a risk, right? You have to make that risk assessment there. But that's what commanders have to think through that. Mm-hmm. And if we need to expose, okay. But if we don't need to, then we need to avoid it.
I think your training aspect is spot on. That can you not have a simulation of it, but can you decrease the charge? Can you change the door such that the charge is effective in breaching the door, and so you get the mechanics of what to do going forward without the large charge? We
still have the research of what's the best position to minimize exposure. Is there another way we can deflect the wave that it doesn't affect? So there is a lot of engineering and stuff like that has to be in the development of our weapon system, right? Mm-hmm. To protect our service members. But short of that, still we have to figure out a way in the training side to minimize exposure.
Sure. This is, we at HEF, we implement research on many fronts. We received an award from Admiral retired Bill McCraven to do continued TBI research. And we're going to use that to partner with a USU researcher. And something I've not seen to date, we would like to take a look at impact on our female warfighters, which I don't think we have to date, to see if there's any difference that might be impacted going forward. So we're on board with you on really understanding what may be at play so that we can protect and prevent, if not eliminate, the risk.
Absolutely.
With regards to the MHS force, so I understand the DepSecDef signed a memo a few months ago aimed at stabilizing the MHS and improving access to care in MTFs. So what exactly does this mean?
Yeah, for many years we've been cutting the direct healthcare system. That's the main target, the MTFs, the military treatment facilities. So any of you that have been around for a while, when I left the Army, active Army in 2005, most of the care we delivered to our beneficiaries were in our MTS, in our military treatment facility. Now 60% of the care is delivered in the network, not in the direct healthcare system. That's an impact. The main impact it has is on readiness. You know, as we talked before, you need patients to keep your proficiency in the clinical side. And we've been shedding the patients outside. We're moving it out. And part of that, we've also moved military medical personnel outside the MTS. So this memo addresses the issue of the readiness and also keeping the trust with our beneficiaries. You know, when people say, I have access issue, I'll say, duh, our numbers are really down on the provider side. So it's not surprising that we're having those issues, right? So what we need to do is now reevaluate how we're going to go about to get the right size for a direct healthcare system. So there's 4 parts to this memo. One is we move the whole organization, the whole MHS, to a requirements-based organization. You see, part of the deal is right now we have no requirements for Role 4 medical care. We have no requirements for 4th generation on the military health system. And we have no requirements for what they call military essential billets, which is the guys in Japan, the guys in AUSA, the guys in Irwin. We're not hiring civilians there. I need to assign military people there, right? So we need to recognize that. So we're in the midst of just doing the overall study to sort out how many requirements are there. And then we also doing a baseline. What do we have in hand? There will be a delta. And then in a year or so, the leadership of the department will know what the risks we're taking. And then remember your days from the Joint Chief of Staff Surgeon, then between the chief and the secretary, we make a decision how to mitigate the risk, right? That's step 1. Step 2, we need to hire civilians. We lost a lot of civilians between COVID, before COVID, not being competitive. So first we need to cut the time to bring civilians, right? 179 days, that's impossible. We need to bring it down to something that is manageable. But on top of that, we have to be competitive. So we need to move into the same competitive that the VA and the rest of the federal system has. The Congress gave us authority to just do that, and we pursue it. It's called Title 38. I don't want to get people crazy about this, but what I'm saying is at least I want to be as competitive as the VA and the other federal health system. And then the third leg is the military people. The primary place of duty of military health care providers is going to be the MTF from here on out, like it used to be, right? So that if you need to be in operation in Poland, so be it. If you need to be in a ship in Atlantic, so be it. But if otherwise, you're going to be taking care of our beneficiaries in the MTFs, and we get a twofer out of that. We keep up the trust with our beneficiaries, but also we keep up the readiness by keeping our clinical skills, right? So that is ongoing right now. The major effort, you're not going to see a major moving parts until 26, so I need to temper this out. And we're going to be moving not to all the MTFs at once. We're going to move to critical MTS first to reattract patients. So the places where we have the patients, the retirees, and the active duty and service members, we're going to put investment in those places first, so we start attracting patients back. And as we succeed into that, then we'll keep expanding. We cannot, it's a huge elephant, so we have to one bite at a time, small, and then chew it and swallow it. And the fourth leg of this, even if I have all the people, I'm not going to have enough people to provide all the care. So example, in behavioral health, that's true. So I need to leverage technology. So we need to bring technology to bear to make it friendly, like if you were in Kaiser, make an appointment online, or maybe get the appointment actually online through your phone with your provider and fix the problem you have. Or down the road, we're doing investment in AI and other technology, right? To see if that can close a gap. Bottom line is, patients don't call to make an appointment. Patients call because they have a problem and they want fix. And we want to provide the fix. how do we provide a fix? Most patients don't care. All they care is that their problem is fixed. So we can provide through technology, we can provide face-to-face, we can provide through telemedicine. That's the approach. And we're going to give the patient the option, right? And make it attractive so they can come back. So we all will be in a better place. So that's kind of a short summary of a very complex document, but it is going to hopefully lead us to the right size and the right capabilities in the direct healthcare system, not only for peacetime care, but also, as we said, for wartime. So there, you cannot delink it. So they're tied together. So that's what we're working on.
Excellent. If I can just tell you from my perspective, an MTF is not simply a platform to deliver healthcare, and even if they are not the same, right? So where there is a troop density is different than where you have an academy, where you have basic training.
Right.
Different requirements at each, so it's not one size fits all, which I know you know. And also, I would advocate that these MTFs can be seen as a research node, and if fully leveraged, you can take advantage of where you do have troop density to conduct research as a means of modernizing in the human domain.
Yeah.
So along those lines, I'm going to ask you a couple of research questions. The first covers psychedelics. What is the status of using psychedelics as a medical countermeasure in the management of PTS and or TBI?
As you know, FDA has not approved any of them to the care, but the NDA authorized us to do research on psychedelic. What I can tell you is we put an RFP into the field for researchers to provide us ideas on how to research this. Hopefully by early 25, we'll close that loop and start funding the research. We're investing first time around $10 million into this research, and hopefully it'll pan out. We really, I'm open-minded, and I think like me, many people in the system are open-minded, so we're not shooting down. There's something we can help our service members and retirees, right, that suffer from PTSD or TBI. We're game.
Excellent. Well, there's certainly some promising early results, and you need research for the FDA to then act on it. So I applaud you for moving forward.
We cannot just, everything we prescribe as a matter of due course has to be approved by the FDA.
Yes, that's correct.
So I don't have the discretion to say, let's go and try this on my own. I can do it on the research side.
Sure.
And we have to inform the patients that we doing research. So they have to be willing participants. But hopefully, if it pans out, then the FDA will grant us a clearance. And it will become. But in research, we've been leading the country in many areas for many years.
Yes, yes.
So that's another part that, as a system, we have to be very proud.
Yes.
That not only those kind of interventions will pay off for our service member, pay off for all Americans.
The same is true with art therapy. You have any comments about the use of art therapy in PTS or TBI?
Absolutely. I mean, early data is showing up that really works out, especially with PTSD and TBI. I just went to the Center of Intrepid, and patients sometimes have problems expressing themselves through the word, but it's amazing what they can do through art. And they can express feelings, and they can express, ideas that sometimes they're not even conscious that they're expressing that. So it is giving us an opportunity to better expression of what they're undergoing. Two, looks like on the cognition side, really, it helps them organize their thought process and is getting better results. And the other part is it helps you when you're able to express your feelings. After you do that, there is a kind of element of peace, an element of stability on the patients we're seeing. So far, but we need to put more research into it. So this is, again, not only for us, we owe it to our patients, we owe it to the country, that we understand this better, so it becomes mainstream in the healthcare across the country.
Well, I applaud you all for allowing art therapists to be within your Intrepid Spirits in the NICO and partnering with the National Endowment of the Arts to pull them in to see if we can create enough data so that this becomes something that insurance can cover going forward.
And it's art, it's music, it's
Yes.
all forms of art.
That's right.
Is critical to this endeavor.
Excellent, excellent. I want to transition very quickly to a question from the audience here. A lifestyle disease such as obesity, diabetes, heart conditions, all have an impact on readiness. The literature is full of evidence that these conditions are improved by better nutrition. Are steps being taken to use nutrition as another approach to mitigating these conditions?
Absolutely. You know, the old Surgeon General of the Army really put a focus on nutrition, and the Army leadership has been looking at this. I remember going to Camp Liberty and see some of the dining facilities. They're quite different from my days. You know, a nice salad bar and opening the options for the service members, right?
Mhm.
Still, they have to have options. So there's an education process here. We cannot force people to just drink to the water and drink it, but we need to facilitate that the environment there's good teaching going on, because we're getting very young service members, so at the right time. So if we teach them early on, that's one, but only it's not enough to teach. We have to make that food available 24/7. So you know, we have to make sure that the facilities are available, the food is available. And then, you know, leadership and everybody has, like everything else we do, we have to show off and push, not only by words, but by action. So I'm encouraged to see by the Army, Navy, and Air Force leadership pushing this agenda.
Excellent. Okay. The Department of Veterans Affairs is the second largest federal agency next to the DoD. How is the MHS partnering with the VA so both can leverage their unique effectiveness and efficiencies?
I tell you what, I talk to the Undersecretary of almost monthly. We've been inaugurating clinics. We have a lot of joint endeavors all across the country. In the last 3 or 4 months, we opened a joint clinic in Portsmouth, Virginia. We went to West Point. We went to Fort Campbell at Blancheville. So there's a lot of joint enterprises. And what we're looking is, okay, where can we partner in such a way we both wins? Give you an example for Campbell. So they develop a primary care clinic. Their referrals is going to go back to the clinic if they're retirees. So now we capture complex cases out of that clinic that before we didn't have. So that hopefully that will keep the surgeons and the orthopaths and the other specialists occupied. That's an example. But we are pursuing, we are really working. That's an area I can very blank tell you. We're working very closely together to look at opportunities, and we're just doing it.
Excellent. Let me end here, if I may, and give you an opportunity to, what would you like America's warfighters to know from their Assistant Secretary of Defense for Health Affairs?
You know, I'm going to talk now like an old soldier. Healthcare for me is about taking care of family. Anyone in uniform is family. That's the way we need to approach it. This is not a business. So we need to sustain that culture, right? That is a family culture. And that starts in the MTFs, that starts in the clinic. When someone say doc, but at the same time, if I needed someone from the green suits, they will protect me, they will care for me. So it's a two-way street. If they're family members, they could trust me with their family members. Not because I was just a doc paid by the U.S. Army, but was a friend, I was a family member, right? So we need to go back to the basics. That's the trust that we need to build. And that's the trust we need to sustain. If we falter there, the whole thing comes unravel. And trying to delink intellectually this process that taking care of the families and taking care of the retirees is like something different from readiness, man, are we going in the wrong direction? It's linked. It's critical to the trust, it's critical to the readiness, and it's critical to this family enterprise. The moment we lose that, I think we lose everything else. So I want to leave that thought in place.
Well, thank you very much, Dr. Martinez Lopez. Is very clear to me and hopefully to the audience here that you're the right person for this position, and I applaud you for everything you're doing in support of the Secretary in leading our warfighters, their families, veterans, retirees, in the health care to make them medically ready to do our nation's bidding, to protect our country, and to support the ideals of freedom and democracy. Thank you very much.
Thank you, Dr. Caravalho.
Wow, what a great discussion, gentlemen. Before we part, I want to inform our viewers of a few upcoming events. AUSA will host a hot topic on aviation on 4 September at AUSA headquarters in Arlington, Virginia. AUSA will host another noon report on 24 September featuring Major General Johnny K. Davis, Commanding General of the U.S. Army Recruiting Command in Fort Knox, and Brigadier General Antoinette Gant, Chief Army Enterprise Marketing Office. The AUSA annual meeting will be 14 through 16 October at the Walter E. Washington Convention Center in Washington, D.C. AUSA's Global Force Symposium will be 25 to 27 March at the Von Braun Center in Huntsville, Alabama. I hope you can join us for an upcoming webinar or event. For more information about any of these events or to register, please visit us at our website at ausa.org. Finally, we thank all of you who support us with your membership. Membership matters. You help us support the Army. Thank you again for attending, and have a great Army Day. Hua.